infective arthritis, which includes the joint infections, pyomyositis, which is the infections around the muscle, bursitis, and necrotizing fasciitis. Next. So today we'll be talking about the acute osteomyelitis and septic arthritis. Acute osteomyelitis is broadly divided into acute osteomyelitis depending upon the duration, which is less than 2 weeks. Subacute osteomyelitis usually presents from 2 weeks to 3 months. It often presents as a localized walled-off cavity in the bone known as Brodie's abscess. Symptoms are milder due to higher host resistance or low bacterial virulence. Third is the chronic osteomyelitis, where the symptoms are present for more than 3 months. It is characterized by the presence of dead bone, sequestrum, and a newly formed bone shell, that is involucrum. And chronic recurrent multifocal osteomyelitis initially was a part of chronic osteomyelitis. Currently, it has been given a new entity. Next. So acute osteomyelitis, the etiology consists of haematogenous contiguous spread and direct inoculation. Haematogenous spread in children therefore occurs from consequence of other infections such as otitis media, pharyngitis, and sinusitis, skin infections that gain access to the bloodstream. So therefore, it is referred to as acute haematogenous osteomyelitis. The second is contiguous spread from limb infections like cellulitis, boils, necrotizing fasciitis. And third is direct inoculation, penetrating injury or surgery or open fractures or puncture wound. Next. So acute haematogenous osteomyelitis most commonly affects the metaphyseal region of long bones with lower extremity locations. Femur accounts for around 27%, tibia to 22%, and fibula around 5%, slightly more common than upper extremity locations, that is humerus, radius, and ulna. Long bone infections account for 75% of cases of osteomyelitis. The non-tubular bone infections occur with a reported incidence of 10% to 11% for pelvic osteomyelitis, 7 to 8% for calcaneal osteomyelitis, and 5% for hand involvement, and 2% for vertebral osteomyelitis or discitis. Next. The causative organisms, according to the age group, include Staphylococcus aureus being the most common. In neonates, apart from Staphylococcus aureus, the nosocomial infections are caused by Streptococcus species, Candida, and Enterobacteriaceae. The community-acquired infections are caused by Staphylococcus aureus, followed by group B Streptococcus, E. coli, and Klebsiella. In infants, from 2 months to 18 months, Staphylococcus aureus is the most common, followed by Kingella, and then Streptococcus, Neisseria, Haemophilus influenza. In early childhood, that is 18 months to 3 years, Staphylococcus aureus, followed by Kingella, Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenza. In children from 3 to 12 years of age, Staphylococcus aureus, followed by group A beta hemolytic Streptococcus. In adolescents, that is 12 to 18 years of age, Staphylococcus aureus, followed by group A beta hemolytic Streptococcus and Neisseria gonorrhea. Risk factors, that is in particular diseases, children with sickle cell disease, Salmonella species is more common, followed by Staphylococcus aureus and Streptococcus pneumoniae. In foot puncture wound, calcaneal osteomyelitis, which is caused because of foot puncture wound, the most common organism is Pseudomonas aeruginosa. In diseases like HIV infection, Staphylococcus aureus, and other organisms, that is the opportunistic infections that are caused by Neisseria, Streptococcus, Salmonella, Cytomegalovirus, Aspergillus, Toxoplasma, Cryptococcus. In chronic granulomatous diseases, Aspergillus species is found most commonly, followed by Staphylococcus, Nocardia, and Mycobacterium species. So accordingly, the empirical antibiotics have to be given. In neonates, apart from Staphylococcus aureus, we have to treat Streptococcus species. So nabzicillin or oxacillin plus gentamicin has to be given. In infants, nabcicillin, oxacillin, or cefazolin. And in early childhood, that is up to 3 years, we have to also include cefotaxime or cefuroxime. In childhood, between 3 to 12 years, nabcicillin, oxacillin, or cefazolin. In adolescents, that is up to 18 year of age, we have to also include gonococcal infections. Therefore, we have to give empirical antibiotics like doxycycline. In sickle cell disease, because of salmonella osteomyelitis, we have to give ceftriaxone. In calcaneal osteomyelitis by Pseudomonas aeruginosa, we have to consider drugs like piptaz and gentamicin. In HIV infection, we have to give broad spectrum antibiotics according to the organism involved. And in chronic granulomatous diseases, we have to give antibiotics like nafcillin, oxacillin, or cefazolin. Next slide. So overall, Staphylococcus aureus is the most common organism detected, but currently isolation of Kingella is increasing age group less than 4 years. So why metaphyseal region is more common? So metaphyseal blood supply has a peculiar arrangement. It consists of loops or sinusoidal arrangement. Epiphyseal blood supply doesn't come in contact with the metaphyseal blood supply in an unfused skeleton. The growth plate acts as a barrier. These loops show sluggish blood flow. Now, the sluggish blood flow is one of the reasons for bacterial lodging and multiplication here. Also, this sluggish blood flow causes bacteria to move into the marrow from the gaps in the endothelium. Pathogenesis is that whenever bacteria multiply, the body starts an immune response. Phagocytic cells are mobilized to this area. In an attempt to bring infection under control, pus formation occurs at this site. As more and more pus is formed, pressure increases at local site and finally trickles down the Haversian and Volkmann's canals to reach the space under periosteum. Apart from that, just one second. Apart from that, the other factors that are involved is that there is lack of phagocytic activity at the metaphysis, and also in Staphylococcus aureus. Staphylococcus aureus is responsible for release of other toxins, multiple toxins. One of important ones include PVL. So there were 2 or 3 studies suggesting that there has been transfacial involvement of pyogenic osteomyelitis also. There were 2 to 3 cases in a case report. I have just showed the images of same in the last slide. I'll show it in the last slide. Next slide. So apart from the anatomy I explained in the previous slide, the anatomy and the proximal femur, it is peculiar and different because in a neonate, the entire epiphysis, it shares a blood supply with the metaphysis. Thus, the infection in the metaphysis can spread into epiphysis and can produce devastating osteonecrosis of the proximal femur. After development of the secondary ossification center, the epiphysis and the metaphysis, they have separate blood supplies. Thus, in the older child, the physis prevents the spread of infection into the epiphysis. However, the metaphysis remains intra-articular and infection may decompress into the joint and produce septic arthritis. The clinical features consists of focal pain, decreased use of the affected extremity is the most common, non-bearing, fever, localized tenderness, swelling, warmth and erythema, poor feeding and lethargy. So the Cerny-Mader classification consists of classification in which the first stage is medullary osteomyelitis, where the infection is confined to the inner marrow cavity. Second is the superficial osteomyelitis, where the infection is limited to the outer bone surface. Third is localized, where a full thickness cortical bone is involved, but the bone still remains structurally stable. And four is diffuse osteomyelitis, which is a permeative disease, causes mechanical instability and requires massive resection and stabilization. And depending on the physiological status of the host, type A is normal host, type B is a host with systemic compromise or local compromise and with diseases like sickle cell disease, and type C is a host where a patient is so severely compromised that the required surgery would be worse than the disease itself. So in neonates, there are 2 types of distinct varieties. The first is encountered in neonates 2 to 8 weeks of age who are typically discharged from the hospital because the clinical features of fever and irritability are usually not present in this age group. Diagnosis and treatment may be delayed. These neonates may fail to mount a typical inflammatory response. A high index of suspicion must be maintained. Aspiration of the bone and joint should be performed liberally, and antibiotic therapy should be initiated when infection is identified, followed by appropriate surgical decision. Here, Staphylococcus aureus is the most commonly identified organism. And the second form of neonatal osteomyelitis is encountered in the neonatal intensive care unit, typically in low birth weight neonates or those who are having peripheral catheterization. Our current guidelines include the use of vancomycin, that is 15 milligram per kg dose every 12 hours without a loading dose, and cefotaxime 50 milligram per kg dose every 8 to 12 hours for neonatal infections. Multifocal osteomyelitis or septic arthritis is commonly identified in neonates. Potentially devastating effect anatomy, development of proximal femur and humerus, suspicion of large joint infection in these neonates should prompt aspiration, and if positive for infection, surgical drainage should be done. Next slide. Uh, In infants, there is loss of maternally conferred immunity, so continued vigilance is necessary when treating osteoarticular infections of large joints in this age category, particularly up to 18 months when long-term sequelae from osteonecrosis and growth disturbance may result. For this reason, we endorse early aspiration and surgical debridement whenever septic arthritis is encountered in early childhood. Coming to the laboratory investigations, complete blood count is a screening study that should be performed in any child with musculoskeletal pain and functional loss suggestive of infection. A WBC count greater than 12,000 cells is identified as one of the risk factors for septic arthritis of hip by culture. Limited sensitivity and specificity as WBC count may be normal or elevated sometimes. ESR infection, usually there's an increase in ESR which gradually increases to a mean peak value following the onset of infection, and it may continue to slowly rise when the child is starting to improve. The ultimate value of ESR is typically at the decision point to terminate the antibiotic therapy. Often it is more than 40 millimeter per hour in bacterial infections. Third is CRP. CRP is currently considered the most sensitive and reliable clinical laboratory test for detecting acute inflammatory reactions. Often it is raised and more than 20 milligram per deciliter in bacterial infection and declines with effective therapy. Currently, it is the best marker to trend the response to therapy. CRP may be used as a guide for transitioning to oral antibiotics. Apart from that, the other laboratory investigations include interleukin 6 and prolactin, but these are not usually done because of higher cost. The microbiological studies include blood cultures and synovial fluid aspiration. Blood culture should usually be taken before administration of antibiotics, and the synovial fluid aspiration is usually done under USG guidance or after surgical evacuation. It should be sent for gram stain, but the gram stain sensitivity is less than 50%. Should always be sent for cultures and PCR to rule out infections like Kingella. Next. The imaging studies start with X-ray. In the initial stages, X-ray is just going to show deep soft tissue swelling, but changes within the bone secondary to osteomyelitis may not occur until 10 to 14 days after the onset of infection and after the loss of 10 to 30 to 50% of bone mineral density at the site of infection. Second is ultrasonography. The ultrasonographic features of osteomyelitis include deep soft tissue swelling, periosteal thickening, subperiosteal fluid collection, and cortical breach or destruction, which typically follows a course of progressive stages based on the duration of the infection. And ultrasound guided aspiration is also done. The image shows three things, that is, C is the capsule, E is the epiphysis, and M is the metaphysis. In the above image, we can see there is thickening of the capsule as compared to the C point in the below image. Therefore, ultrasound is usually probably used to guide aspiration and to see if there is any collection. Next slide. Uh, Therefore, the investigation of choice, which is currently important, is MRI. In the second image, we can see the distal tip of the fibula and the pus around the fibula. And the third image is the axial image showing again pus around the tip of fibula. Therefore, MRI currently is the gold standard investigation for screening and for detection of osteomyelitis. Next slide. Again, this not only for diagnosing the osteomyelitis, but also MRI is important to tell us the extent of osteomyelitis. Next slide. So, MRI is the most powerful diagnostic imaging currently available, and the sensitivity of MRI has been reported to be as high as 98%. Why? Because it detects marrow edema as early as 24 to 48 hours. It can delineate the joint involvement, periosteal reaction, myositis, or even abscess. But the only disadvantage of MRI is that it is expensive, and in kids or in neonates, it might need sedation. The last investigation I'm talking about is nuclear imaging. Nuclear imaging consists of three-phase bone scanning, and it is sensitive probably for multifocal disease. It is less specific. It may show false positive in trauma and evaluation. PET or CT has high sensitivity, but the radiation limits permit pediatric use. So, nuclear imaging is of importance in children who have mimics like bone infarction or scan, which usually show cold spot on nuclear scan as compared to osteomyelitis, which is seen as a hot spot. Next. So, this is the three-phase bone scan used to diagnose the left ulnar osteomyelitis. Next. Initial treatment consists of appropriate splinting of the limb, then broad spectrum antibiotics before starting the appropriate antibiotics, hydration and supportive measures, and imaging to rule out an abscess. Principles in treatment of acute hematogenous osteomyelitis include an appropriate antibiotic before pus formation, and if at all pus has formed, appropriate and timely surgical evacuation should be done. However, the surgery should not damage further already ischemic bone or soft tissue and the physis, and the antibiotic should be continued after surgery. Next. The antibiotic dosage for osteomyelitis is usually 2 to 3 times the standard dose to ensure a peak serum bactericidal titer of 1:8 or greater. The management of acute hematogenous osteomyelitis begins with intravenous administration of an antibiotic to cover the most likely causative organism until a more specific antibiotic can be chosen based on the culture and sensitivity results. The duration of initial intravenous antibiotic therapy varies according to the relative severity of illness of the affected child, ranging from 3 to 14 days, and is often governed by improvement of the CRP level, resolution of the bacteremia and fever, and an overall sense of clinical improvement. Oral antibiotic duration of 3 weeks with follow-up laboratory studies performed at approximately 1 to 2 weeks after hospital discharge to ensure an appropriate downward trend is occurring, and again near the time of antibiotic completion to ensure normalization of the ESR. Next. So if there is no abscess or there is no subperiosteal collection, we continue the antibiotics, we do the clinical monitoring, we monitor CRP trends. If CRP level is rising, the child needs a immediate surgical procedure, and if there is no improvement in 24 to 48 hours, we usually prefer surgery. But what if there is an abscess or there is no response to the antibiotics? We perform few steps. These include decompression of the subperiosteal abscess, decompression of the medullary canal by a cortical window or multiple drill holes, then curettage of the metaphysis and closure with insertion of a drain. So this is an image of distal tibia osteomyelitis. The first image shows pus pointing, and the second is the pus that was drained. Third is drilling in the distal metaphysis, and fourth is the cortical window created, following which curettage was done, and the patient was started on antibiotics specific to the culture. Another case of a 13-year-old boy. He complained of pain in the right knee. The initial x-rays was normal, but the MRI was suggestive of acute osteomyelitis in the epiphyseal metaphyseal region of right tibia. So a plan for debridement and corticotomy was done. Incision was taken at the anterolateral, according to the anterolateral approach. The proximal tibia was exposed. Thorough debridement of the wound was done, and isolation of the common peroneal nerve at the fibular neck. Next. Pus from the epiphyseal region was drained by carefully drilling multiple holes in the epiphyseal region. And the last two images, they show 1 year follow-up of and the range of motion was normal. Next. And the last case, this 18-month-old boy presented with left hip pain and limp, and he had a preceding history of rhinitis, fever since 3 days, and was non-weight bearing. The WBC count was 23,000, CRP was 7.2, and the ESR was 52 millimeter per hour. So diagnosis of osteomyelitis of proximal femur was done. And the next. MRI was done, and the MRI showed hyperintense signals in the in the left proximal femur, and a plan for biopsy was done. Next. So surgically closed needle biopsy was done, and the microbiology came out to be methicillin sensitive Staphylococcus aureus. Therefore, intravenous therapy with ceftazidime and oxacillin for 7 days, followed by oral flucloxacillin, flucloxacillin for 4 weeks was given. And 6 months post discharged, the child showed full range of motion at his left hip, and the gait was normal. Post surgery, we have to continue the antibiotics, and we, according to the CRP trends, we decide when to start the oral antibiotics. Splinting and non-weight bearing should be done to prevent fractures. First, because of as a pathological fracture, and second, because we have done multiple drilling and corticotomy at the osteomyelitis site, and we have to discharge the patient with oral antibiotics. Next. So the complications include chronic osteomyelitis. Most of the times, chronic osteomyelitis occurs as a result of acute osteomyelitis or an untreated acute osteomyelitis, or one which is delayed in treatment. Next. The second one is damage to the physis. In the MRI, we can see there's overgrowth on the medial side. So that can lead to either growth retardation or angular deformity. In this image, we can see the genivalgum at the left knee. Not only that, there could be limb length discrepancies, there could be avascular necrosis, and also there could be pathological fractures. Next slide. Next slide. Acute osteomyelitis should be differentiated from few entities, one of which is juvenile idiopathic arthritis, which is an autoimmune polyarticular chronic inflammatory joint disease. The symptoms persist for more than 6 weeks, making it a chronic issue, whereas AHO is usually acute and less than 14 days. Also, the symptom pattern is different in JIA. It is characterized by severe morning stiffness that improves with activity throughout the day. And in AHO, pain is constant and worsens with any weight bearing. And the involvement of joints in JI is knee, wrist, and ankle more than hip. And in JI, the cultures, that is synovial fluid and blood cultures, will be completely sterile. And the second one is malignancies like Ewing's sarcoma or leukemia. They usually have a subacute to chronic presentation. They present with night pain, deep bone pain, swelling, low-grade fever. The ASR and CRP may be elevated. However, the X-ray show lytic or permeative lesions, and MRI usually shows bone marrow infiltrations. The second topic, that is septic arthritis. Septic arthritis is a surgical emergency that requires prompt recognition, urgent incision and drainage, because delay leads to long-term sequelae. Joints that are particularly susceptible to the spread of infection from an adjacent osseous source include knee, that accounts to almost 31%, hip 23%, ankle 18%, and shoulder to 14%. This susceptibility is largely the result of intracapsular location of the metaphysis in these joints. Septic arthritis can be differentiated from osteomyelitis by presence of an irritable joint, which is provoked by gentle passive motion, whereas joint motion usually does not substantially provoke symptoms in children with osteomyelitis. Risk factors for septic arthritis are usually prematurity, low birth weight, neonates in intensive care unit, and neonates who have already undergone invasive procedures like umbilical or venous catheterization. Staphylococcus aureus remains the most commonly identified organism. Apart from that, the other organisms that are involved includes Haemophilus, Kingella, Neisseria, and Enterobacteriaceae. And septic sacroiliitis is most commonly seen with Mycobacterium tuberculosis. The clinical features include localized swelling, effusion, warmth, tenderness. The hip rests in flexion, abduction, and external rotation, and there is severe pain with passive motion. X-rays are inconclusive in initial stages, but in infants, prior to ossification of the femoral head, widening of the joint space can be seen by lateral displacement of the proximal femur. Also, there can be subluxation or dislocation. So diagnosis, we have to keep a high index of suspicion, get other counts like total count, differential count, ESR, CRP, which is usually raised. Joint aspiration should be done using ultrasound, which actually acts as diagnostic or therapeutic. Joint fluid obtained by aspiration should be sent for gram stain and culture as well as cell count. A WBC count greater than 50,000 with a predominance of polymorphonuclear leukocytes is the characteristic of septic arthritis. Septic arthritis should be differentiated from transient synovitis. Transient synovitis is one of the most common causes of hip pain in children and is responsible for up to 9.9% of pediatric emergencies. In transient synovitis, the children usually limp but can bear weight, less severe pain, and they have less severe pain as compared to septic arthritis, and they might improve within 14 to 24 to 48 hours. They are afebrile or have low grade fever, and ESR CRP is slightly on the lower side. Also, on investigations, there is decreased perfusion at the femoral epiphysis on fat suppressed gadolinium enhanced coronal T1 weighted MRI that is useful for differentiating septic arthritis from transient synovitis. So the criteria for septic arthritis include history of fever, history of non-weight bearing, ESR more than 40 mm per hour, and WBC count more than 12,000 cells. Surgical management could be ultrasound guided or fluoroscopy guided aspiration, arthroscopy, drainage and irrigation, or open arthrotomy and debridement. Next. So the aspiration of the hip joint, it could be done from three sides, that is the anterior, lateral and medial. Anteriorly, we palpate the femoral artery in line with the inguinal ligament and then insert a needle approximately 2 cm distal and 2 cm lateral to this point. Then advance the needle at an angle of 45 to 60 degree posterior medial into the joint. Confirm the position of the needle using image intensifier or ultrasound. In lateral, we insert the needle just anterior and inferior to the tip of greater trochanter. Then advance the needle into the joint in proximal and medial directions with the hip in internal rotation. When aspiration from medial approach has to be done, we have to flex and abduct the hip, insert the needle inferior to the proximal adductor longus tendon, and advance it towards the femoral head. We use this approach only in children less than 1 year of age.
Sorry, Sayali, to disturb you. Karthik or Mohit, can one of you make a new link? The meeting is there for less than 1 minute.
I think we can, wrap up and then continue maybe, when we meet up. ठीक है, make a new link. Hello.
Okay.
Yes,
Yes.
sir. In arthroscopy, the second is arthroscopy. In
Wait. I'm creating a new link.
LT, AC is the acetabular cavity, and the S is the inflamed part of the synovium that is seen in the inferior part. Next. And lastly is arthrotomy. Open arthrotomy still remains the gold standard for hip joint. It could be done by anterior approach or lateral approach. The anterior approach is usually the lower part of Smith-Peterson. You make a vertical incision around 1 centimeter below the anterosuperior spine. You protect the lateral femoral cutaneous nerve, expose the sartorius on the medial side and the tensor fasciae lata. Then you separate and do blunt dissection between two. Identify the lateral rectus border and retract it medially, expose the hip joint capsule, and we protect the lateral femoral circumflex artery. Once we open the capsule, we evacuate the pus, remove all the non-viable tissue, irrigate the joint, leave the capsule open, but close the skin, leaving drains. Next. There were few articles where arthrotomy and arthroscopy was being compared. So early range of motion of the hip is encouraged as soon as pain becomes tolerable. But hip arthroscopy and irrigation are superior to arthrotomy, but it is technically more demanding. And by hip arthrotomy, a better view of joint and sufficient irrigation can be provided. Next. Post-operative care, post-operatively immobilization of the hip joint in 40 to 45 degree of abduction with a hip spica or skin traction for 4 to 6 weeks to prevent flexion, adduction deformity, which may predispose to subluxation or dislocation of the joint. So the end result of septic arthritis usually there is destruction of the epiphysis, the cartilage and the growth plate that can lead to unstable joint. That could be shortening and limb length discrepancies, and there could be a need for multiple surgical interventions. Next slide. Tubercular arthritis is usually chronic and insidious and is a granulomatous inflammation caused by Mycobacterium tuberculosis. Here, classically, transfacial spread is seen. The synovial membrane is forms studs. There is proliferation, thickening, studding of its inner surface with tubercles. The tubercular granulation tissue covers the hyaline cartilage, and eventually there is destruction of the articular surfaces, most extensively in the peripheral areas. As there is increase in the intraosseous and intraarticular pressure, the bony cortex or the joint capsule becomes perforated and then cold abscess forms. The clinical next. In clinical features of tubercular arthritis, the child is usually ill and has weight loss and is fatigued. The lesion is usually example in the hip. The initial symptom may be limping, and there are night cries. Also, in superficial infections, superficial joints like in knee or elbow, there is effusion and synovial thickening, which is seen as bogginess and fullness. Apart from that, local heat and redness are usually absent, and tenderness is minimal. So PCR of the joint fluid is the method of choice for diagnosis for tubercular arthritis. In radiological findings, we have to mention. I would like to mention that this destruction of the hyaline cartilage by the tuberculous granulation, but it is a slow process. In contrast to suppurative arthritis, in which destruction of the articular cartilage and joint space narrowing occur early in the course of the disease. So, next slide. So the reactive bone formation is characteristically absent in early stages of tuberculous arthritis, and if it remains untreated, the entire articular cartilage is eroded and extensive destruction of the joint occurs, leading to ankylosis. Bony erosion is more common in tuberculous arthritis than in pyogenic arthritis, whereas abnormal subchondral marrow signal intensity is more often in pyogenic arthritis. So this in the left proximal femur, we can see a lesion which was later on suspected to be tuberculosis. A biopsy was done and appropriate therapy was started. Next. Yes, a biopsy or biopsy of regional lymph nodes should be done in tuberculosis. Last topic, the infections in the other locations, spine, pelvis, and foot. The next. So pyogenic infection spondylodiscitis usually occurs at L3, L4 or L5, L4, L5 disc space, and Staphylococcus aureus is the most common organism. The pathogenesis is that infants and young children up to age of 7 years, they demonstrate the persistence of blood vessels that penetrate across the vertebral end plate into the disc space and to the annulus fibrosus. The end organ circulation of the vertebral end plate is analogous to that of metaphyseal portion of long bones, whereby the low flow through venous sinusoids may result in bacterial access to the extravascular space. The initial X-rays usually are not suggestive, but when we get an MRI done, we can see there is at the end plate there is hyperintensity. Next. So diagnosis of pyogenic spondylodiscitis in children less than 4 years, they refuse to walk or sit, there is irritability, limping, loss of lordosis. And in children more than 4 years, there is back pain, fever, point tenderness upon palpation, and limited spinal mobility. The ESR is elevated in more than 90% of cases and is often a more reliable initial marker than CRP, and WBC is usually normal. The radiographs at the onset of discitis are usually normal, and after 2 to 3 weeks, they show the disease progression and often require other advanced techniques. The primary X-ray features they show the loss of disc height, periosteal abscess, or bone consolidation, and lately they show the destruction of the vertebral body, irregularity of the vertebral erosions, and plain X-rays reveal isolated intervertebral disc space narrowing when symptoms present for 1 week or more. By end of 3 to 4 weeks, adjacent vertebral end plates have there is erosion of the adjacent vertebral end plates as well. So MRI with contrast is the gold standard for diagnosis of this, and CT guided percutaneous biopsy may be considered for cases that fail the empirical therapy, or tumor or tuberculous infections are suspected, because Staphylococcus aureus here also is the most common organism. Next. Treatment is again empirical antibiotic regimens against Staphylococcus aureus and Kengar in children less than 4 years, which includes ceftriaxone plus vancomycin or clindamycin. And the treatment duration. So currently, early transition strategy is used, which says that switch from IV to highly bioavailable oral antibiotics once the child is clinically improving, afebrile, and the inflammatory markers are clearly trending down. So the recent 2024 studies show reducing the intravenous duration to 8 to 14 days is safe and reduced hospital complication. Total duration, that is typically 4 to weeks, total IV plus oral. Prolonging the therapy beyond 6 weeks for uncomplicated cases has not shown any improved outcome. So this the previous MRI and this MRI, later on it was treated with empirical antibiotics against Staphylococcus aureus for 1 month, and the MRI changes, we can see the evident MRI changes also. Next. The surgical management is rarely required in case of pyogenic discitis, but absolute indications are only if there are signs of cord compression or chorda equina, if there is severe instability or deformity at the vertebral body, if there is failure of medical management, that is, if there is lack of improvement in inflammatory markers, despite giving culture-directed IV antibiotics for minimum 48 to 72 hours, and if there is uncontrolled sepsis or there is presence of massive epidural abscess that does not respond to medical therapy. Next. So in food, the calcaneal osteomyelitis is usually caused because of haematogenous root and puncture wounds. Bacteria, they selectively lodge in the metaphyseal equivalent region of the posterior tuberosity of calcaneus adjacent to the apophysis, where the vascular anatomy mimics that of metaphysis of a long bone. A delay in treatment has been associated with apophyseal plate destruction, with secondary growth arrest and permanent deformity of the involved calcaneus. So the image, the child was brought to the OPD with complaints of heel pain, but he was given a slab and sent home. Then after 8 or 10 days ten days, the MRI was done, which suggested of calcaneal osteomyelitis. So a proper debridement, formal debridement was done, and then drilling was also done to discharge if there's any foci, and then he was starting on appropriate antibiotics. Next. In pelvics, the most common site for pelvic osteomyelitis is ischiopubic synchondrosis, because this bone, the bone in this region, it resembles a metaphyseal equivalent with endarteral circulation leading to loops and sinusoids, and this site is ideal for haematogenous osteomyelitis. So the clinical presentation in pelvic osteomyelitis could be in three patterns. The first one is lumbar syndrome that occurs as the irritation of the lumbosacral plexus and shows clinical features like pain in the back, and second is gluteal syndrome that results from a subgluteal abscess and creates buttock pain. Third is the abdominal syndrome, which mimics an acute abdomen and results from irritation of peritoneum near a site of iliac inflammation. So infection suspected of having a pelvic organ should also be evaluated with MRI to yield the greatest likelihood of an accurate diagnosis. This was a case of ischiopubic osteomyelitis, and he was treated with antibiotic therapy for 1 month, oral followed by parenteral. Next. In systemic disease and infections, I'm talking about sickle cell disease. The others which have to be taken care of are chronic granulomatous diseases and HIV. Next slide. Sickle cell anemia and osteomyelitis. Sickle in children of children sickle cell anemia, they are more susceptible to osteomyelitis and septic arthritis because of multiple factors. Few of which I mentioned here include one being functional asplenia. There is no there is autodigestion of the spleen. Second is frequent tissue infarction, and third is poor opsonization of polysaccharide antigens from impaired complement activity. And salmonella is more common in patients with sickle cell disease because of intestinal wall microinfarctions that allow the organism to gain access to the circulation. So these children should initially be treated for crisis with hydration, lot of hydration, then analgesic, and then oxygen while withholding the antibiotics. The laboratory screening is performed for infection along with serial clinical examinations. And if there is no improvement within 24 to 48 hours of conservative observation, then suspected foci should be aspirated and empirical antibiotics should be initiated as soon as possible. Last slide. The culture negative acute hematogenous osteomyelitis. So usually it accounts for 40 to 60% of all bone and joint infection due to prior antibiotic exposure before the bone or blood cultures are drawn, or it could occur as a result of low bacterial load or the presence of fastidious organisms like Kingella that are difficult to grow in standard cultures. The incidence of long-term sequel, the temperature before admission, baseline laboratory indicators, and possibility of surgery in the culture negative group of patients is significantly lower than those in the culture positive group. How to treat this? So for infants, that is 6 or toddlers between 6 months to 4 years, we have to cover organisms like Staphylococcus aureus and Kingella. So common regimen is first generation cephalosporin plus ceftriaxone. For older children, Staphylococcus aureus is the primary target. Therefore, depending on the prevalence of MRSA, treatment is typically given with clindamycin or vancomycin. And we have to again go for early transition to oral therapy. No need to keep a culture negative patient on IV antibiotics for weeks. Once the child is clinically improving, afebrile for 24 to 48 hours, and their CRP has peaked and is definitively trending downward, they can be safely transitioned to highly bioavailable oral antibiotics. And the total duration of therapy, currently guidelines suggest a total duration of 3 to 4 weeks for uncomplicated culture negative acute hematogenous osteomyelitis that responds well to the initial therapy. So the take-home message is maintain high suspicion in children with fever plus focal bone or joint pain or refusal to bear weight. Obtain the blood cultures before antibiotics when safe. Do not delay therapy in unstable or toxic appearing children. The CRP trends guide response. A consistent decline supports clinical improvement. Use MRI early to define the extent or abscess. Ultrasound helps to detect the joint effusions and guide the aspiration. Empirical therapy should target Staphylococcus aureus and adjust for age. Kingella should be always included in age less than 4 years. Gram negatives in neonates, Salmonella and sickle cell disease, and local MRCA, methicillin-resistant Staphylococcus aureus prevalence. Transition intravenous to oral when clinically improved, afebrile, tolerating oral, organism is susceptible, CRP is falling, and no undrained abscess. Urgently decompress septic hip or shoulders, drain abscesses, involve orthopedics, and monitor closely. Last. These are the references. Thank you.
Okay, quite extensive. Fine. I think we will stop for now. Few